So I want you to try something for a second. Like wherever you are listening to this deep dive right now, just take your thumb and press it firmly into the inner corner of your eye, like right up against the bridge of your nose.
Right, yeah, you can feel that really solid ridge there.
Exactly. And you probably think of your skull as this thick protective helmet, right? Like a solid vault for your brain and your eyes. But right beneath your thumb, separating the inside of your nasal cavity from your actual eyeball, is this wall of bone that's like no thicker than a single sheet of printer paper.
Yeah, it's an incredibly fragile piece of architecture. I mean, if you go just a few millimeters above that paper-thin wall, you literally hit the floor of brain cavity.
Which is just wild to me. So welcome to the deep dive. Today we are stepping into this diagnostic and surgical landscape that is honestly just terrifyingly complex.
Terrifying is definitely the right word for it, yeah.
Right. We're pulling from this incredibly dense, highly detailed body of medical and surgical protocols from the world of otolaryngology, so ear, nose, and throat surgery. But specifically, we are zooming in on rhinology, which is hidden spaces right behind your face.
It is basically the absolute definition of high-stakes geography. Like when we look at the surgical manuals and the anatomical mapping required to operate in this space, you realize the margin of error isn't measured in inches, it's measured in like fractions of a millimeter.
Yeah. And so our mission today is to decode this bizarre microscopic terrain. Because the nasal cavity, it isn't just a tube you breathe through. It is this tightly packed, millimeter by millimeter labyrinth that borders, well, your central nervous system.
Exactly.
So we're going to look at the anatomy, the bizarre organisms that invade it, the heavy-duty pharmacological warfare used to fight moth, and ultimately the intense surgical demolition required when those hidden cavities go rogue.
And I think the recurring theme you'll notice here is absolute unforgiving precision. I mean, a surgeon entering the space is operating in a tiny dark cavern.
Correct.
One wrong move, like literally 1 millimeter too far in the wrong direction, and you aren't just giving someone a bloody nose, you are potentially causing irreversible blindness or catastrophic brain injury.
It is so intense. And I mean, before we can even talk about how doctors fix these problems, we kind of have to understand the terrain first, right? We have to map the labyrinth. And when I was going through the spatial descriptions in the source material, the only analogy that made sense to me was like spelunking in a really dangerous cave system.
Oh, that's a great way to think about it, actually.
Yeah, because you have these wider rooms, but to get from one room to another, you have to squeeze through these incredibly tight, treacherous bottlenecks.
That's a highly accurate way to visualize it, because the sinuses, they aren't just empty balloons, they're a complex series of interconnected chambers, and the most critical bottleneck of all is this area called the frontal recess.
Right, the frontal recess. And what's wild to me is that it isn't really a thing, like in the way your femur is a thing.
Right, it's not a solid object.
It's an empty space. It's this 3D transitional zone that connects your frontal sinus, which is that big cavity up behind your forehead, down into the drainage pathway of your nose, which the notes call the ethmoidal infundibulum.
Yeah, so think of it like a funnel, but it's a funnel that is surrounded by incredibly critical structures. I mean, the anatomical mapping here is as precise as a surveyor laying out a skyscraper. The superior boundary, so the roof of this recess, is formed by the frontal sinus itself and the fovea ethmoidalis.
Okay, fovea ethmoidalis. I love the terminology here, but what exactly is that? Because it sounds like a spell from Harry Potter or something.
It kind of does, yeah. But it's essentially just the roof of the ethmoid bone. So the ethmoid is that spongy bone sitting right between your eyes. Okay. And the fovea ethmoidalis is the literal ceiling of your nasal cavity. But more importantly, it is the floor of your anterior cranial fossa. So your brain is sitting right on top of it. And these tiny nerve fibers that are responsible for your sense of smell, they actually punch right through it.
So you're operating in a funnel where the ceiling is literally the brain, and the walls are equally treacherous, right? You mentioned that paper-thin bone earlier. The medial wall of the eye socket. The clinical term for it is the lamina peperatio.
Yeah, which translates directly from Latin to the paper-thin plate. And I mean, that is not an exaggeration at all. It is literally translucent.
Wait, you can see through it?
Yeah, if you hold skull up to the light, you can see right through it. So, just consider the surgeon's reality for a second. You are maneuvering sharp metal instruments in a dark, wet, tiny recess. If you push slightly too hard against the lateral wall, you break the paper-thin plate and enter the eye socket.
Oh my god.
And if you push slightly too hard upwards, you break the fovea ethmoidalis and you enter the brain.
Okay, my heart is already up just thinking about holding a tool in there. And the terrain, it isn't uniform either. The ethmoid sinus is that spongy area between the eyes. They're divided into interior to the front and posterior to the back.
Right, exactly.
And the protocols highlight these critical differences between them that the surgeon just has to know by feel.
Because you can't always see perfectly in there, You really rely on tactile feedback. The ethmoid sinuses are basically a honeycomb of air cells. But in the posterior ethmoid, so the section further back in your head, the overall size of the orbital cavity is smaller.
Right.
The skull base, however, is thicker.
Which I would assume is a good thing, right? Like a thicker ceiling means you're less likely to accidentally poke into the brain.
Exactly. I mean, from an evolutionary standpoint, that thicker bone offers more structural support near the center of the skull, so it gives the surgeon a slightly larger safety margin, which is nice. But, nature always demands a trade-off.
Always.
In the posterior ethmoid, the individual honeycomb cells are larger, and there are actually fewer of them.
Okay, but why does that matter? Like, a larger room in a cave sounds easier to navigate than a bunch of tiny ones.
Yeah, you'd think so, definitely. But larger cells actually distort the surrounding anatomy. They push against the optic nerve and the major blood vessels.
Oh, I see.
So when a surgeon enters a massive posterior ethmoid cell, they lose their standard landmarks. It's super easy to get disoriented and think you are in the main nasal cavity when you're actually boxed into a blind corner right next to the optic nerve.
That is terrifying. So that's our map, basically. A dark, wet, paper-thin honeycomb flanked by eyeballs and brain matter.
Pretty much.
So now let's look at what happens when this cave system gets invaded. And we aren't talking about a common cold virus here. The really intense cases in the notes involve fungal sinusitis, like literal fungi invading the face.
Yeah, fungal infections in this environment are a completely different biological beast than bacterial infections. I mean, fungi thrive in dark, warm, highly humid spaces.
Right.
So your sinuses are essentially prime real estate for them to set up a colony.
And sometimes they form something called a fungal ball, which honestly sounds exactly like what it is.
It really is. It is literally a dense, intertwined clump of fungal hyphae, which are the branching, root-like filaments of a fungus, and it grows and packs itself into a solid mass inside the sinus.
Gross.
The genus Aspergillus is almost always the culprit here, and it really loves to set up shop in the maxillary sinus, which is that large cavity right behind your cheekbones.
Okay, but here is why I have to stop and ask about a completely bizarre medical connection from the sources. Because when looking into the causes of these maxillary fungal balls, there is a specific, well-documented trigger, and it's dental work.
Yes.
Specifically, having a root canal or a filling on your upper teeth. Like, how does a trip to the dentist result in a literal ball of mold growing inside your cheek?
It's one of those brilliant, terrifying examples of how interconnected our bodies are, really. So the roots of your upper molars and premolars, they don't just sit in solid jawbone. They often extend right up to the floor of the maxillary sinus. Okay. In some people, the roots actually poke up into the sinus cavity, covered only by a super thin layer of membrane.
Wait, really? So my tooth roots are basically dangling into my nasal cavity?
Exactly. Now, imagine a dentist is performing a root canal, or, packing a filling into one of those upper teeth. They use materials that contain trace amounts of heavy metals, often zinc, to seal the tooth. Right. If they push just a tiny bit too hard, microscopic amounts of that dental material can extrude through the tip of the root and pop right into the maxillary sinus.
Okay, I think I see where this is going.
Yeah, so fungal spores like Aspergillus, they are everywhere. You inhale them every day. Usually your immune system just clears them out, no problem. But Aspergillus absolutely loves zinc.
Wow.
Zinc acts as a metalloenzyme catalyst for the fungus. It supercharges its growth. So a spore lands on that microscopic speck of dental filling, uses the zinc as fertilizer, and basically begins to rapidly multiply, layering over itself until it forms this massive solid ball.
That is wild. Like a microscopic crumb of a filling supercharges a spore into a cheek fungus.
It's great.
And it's noted that these simple fungal balls, they don't usually produce allergic mucin, right? That thick, peanut butter-like inflammatory mucus. It's just a solid mass sitting there, taking up space until it gets surgically removed.
Right, a fungal ball is generally non-invasive, it just squats there. The real nightmare scenario is invasive fungal rhinosinusitis.
which is FRS.
Exactly.
Yeah.
That's when the fungus stops being a swatter and starts actively eating the building.
And the breakdown here in the notes is intense. There's acute invasive FRS, which operates on a terrifyingly fast timeline, like less than 4 weeks from onset to severe crisis.
Yeah.
And it almost exclusively targets the immunocompromised, right?
We're talking about patients with uncontrolled severe diabetes or patients undergoing really heavy chemotherapy. Their immune system is basically offline, so the fungus just invades the blood vessels themselves.
Ah.
It causes thrombosis, which is clotting, and that cuts off the blood supply to the tissues of the nose and face.
Which means the tissue just dies.
It literally dies and turns black. It's called necrosis. And the treatment is an immediate, massive surgical debridement. I mean, the surgeon has to go in and aggressively cut away every piece of dead or dying tissue. Sometimes they're removing the palate or parts of the face, all while pumping the patient full of systemic antifungals and using hyperbaric oxygen therapy just to try and force oxygen back into the surviving tissues.
That is so brutal. But then, on the complete opposite end of the spectrum is chronic invasive FRS. And this one plays the long game, lasting for more than 12 weeks, usually caused by Aspergillus fumigatus.
Right.
And it specifically targets the ethmoid and sphenoid sinuses, which are the deep points right next to the brain.
Yeah, chronic invasive FRS is incredibly insidious. Like, it doesn't trigger that massive sudden tissue death of the acute version. Instead, it slowly, quietly secretes enzymes that erode the surrounding bone over a period of months.
So you wouldn't even know what's happening right away.
Exactly. The patient might just think they have a stubborn recurring sinus headache. But meanwhile, the fungus is silently chewing a pathway directly toward their optic nerve or their cranial bolt.
And if that wasn't terrifying enough, there's a third variant mentioned, chronic granulomatous FRS, also lasting more than 12 weeks. But this one is caused by Aspergillus flavus.
Yeah, and the key mechanism here is in the name, granulomatous.
Right.
So your immune system realizes it can't outright kill the fungus, right? So it tries to basically imprison it. It sends waves of white blood cells to surround the fungal spores, layering over them to create these dense nodules of inflammation called granulomas.
Okay, so it's walling it off.
Trying to, yeah. But over time, this creates a massive, sprawling, inflammatory tumor-like mass that expands across multiple sinus cavities, just crushing everything in its path.
Unbelievable. So we know them out, and we know the enemies. But a surgeon doesn't just, immediately start cutting. You have to assess the battlefield first. So let's look at how the medical community stages this fight and the pharmacological arsenal they use before they ever set foot in an operating room.
Absolutely. Because surgery is always a physical trauma. You only induce trauma when medical management is fundamentally failed. But first, you really need a way to measure the disease objectively.
And they use staging systems for that. The most prominent one here is the Kupferberg staging system. It's basically a way to visually grade the severity of the damage inside the nose using an endoscope.
Right.
And I was trying to guess what these grades actually meant physically. Grade 1 is normal mucosa, so just pink, healthy lining. Grade 2 is mucosal edema. That's a swelling.
Yes, exactly. The tissue is retaining fluid because of inflammation. It looks kind of puffy and pale.
Okay, then grade 3 progresses to polypoidal edema, so the swelling is getting worse. And then grade 3 is full-blown sinus polyps. Now, I always hear the word polyp, and I immediately think of a tumor, but that's not what this is it?
Not at all, actually. A nasal polyp is not a neoplasm. It's not cancer. So imagine the lining of your sinus becomes so chronically inflamed, so packed with immune cells and fluid, that gravity simply takes over.
Oh, wait.
The tissue sags down and fills with water, creating these pale, teardrop-shaped bags of jelly. When a patient reaches grade 4, those waterlogged bags can become massive enough to literally pack the entire nasal corridor.
So nothing is getting through.
Right. No air can get through. No mucus can drain out.
You essentially have water balloons blocking your airway. There's also the Philpott-Jobber staging system mentioned, which just proves specialists have, multiple ways of tracking this, but the end result is the same. The plumbing is completely blocked.
Completely blocked, yeah.
So how do you fight it? The protocol is called maximal medical therapy, and it is a gauntlet. 4 to 6 weeks of sustained chemical warfare.
It's an absolute barrage. The whole goal is to aggressively reset the immune system and eradicate any lingering bacterial superinfection.
Yeah, the list of medications is massive.
Yeah.
You got culture-directed broad-spectrum antibiotics for up to 6 weeks, topical steroids sprayed directly into the nose,
Right.
short courses of oral corticosteroids to suppress systemic inflammation, antihistamines for allergy control, decongestants, mucolytics to literally dissolve the thick mucus.
Yeah.
But I really want to zero in on the antibiotics here, because there's a specific class highlighted, macrolides.
Oh, yeah. Macrolides are a fascinating part of modern rhinology. Things like clarithromycin or azithromycin.
Right, and standard logic says antibiotics kill bacteria. You have a bacterial infection, you take a pill, the bug dies. But the protocol specifically highlight macrolides not just for bug killing, but for their anti-inflammatory effect.
Yes.
Specifically targeting neutrophils and interleukins like IL-4 and IL-8. Can you really explain that for me, like what these drugs actually do?
So this is where we really have to look at the mechanisms of chronic disease. In chronic sinusitis, the bacteria aren't actually the main problem anymore.
They aren't.
No, the problem is your own immune system overreacting. So neutrophils are your body's frontline infantry. They're white blood cells that rush in to destroy invaders. And interleukins, like IL-8, are essentially the chemical distress flares that tell the neutrophils exactly where to go.
So the body's just constantly firing off distress flares.
Exactly. The sinuses are just flooded with interleukins, calling in millions of neutrophils. But when the neutrophils show up and find out the bacteria are hiding behind thick biofilms, they just start indiscriminately dumping toxic enzymes.
Oh no.
They destroy the bacteria, sure, but they also destroy your own sinus lining in the process. It's massive collateral damage.
So where do the macrolides come in?
Well, macrolides are unique because they actually act as immunomodulators. They reach into the cellular machinery and turn off the production of IL-8. They literally stop the distress flares. So you aren't just killing bacteria, you are actively telling your own immune system to stand down and stop destroying your face.
That is incredible. A drug pulling double duty. But what about the really bad actors, the fungi? Because when you have to break out the heavy-duty antifungals, the stakes seem to go through the roof in these notes.
Systemic antifungals are brutal, mostly because fungi are eukaryotes, just like us. Their cells are structurally much closer to human cells than bacteria are.
Right.
So finding a chemical that kills a fungal cell without killing your cells is chemically very difficult.
And the protocols list amphotericin B as a primary weapon, but right next to it there's a glaring warning. Nephrotoxic. It destroys your kidneys.
Yeah, in the medical community, amphotericin B is colloquially known as amphoterrible. It is an incredibly harsh drug.
Why does it attack the kidneys specifically though?
So amphotericin B works by binding to a molecule called ergosterol, which forms the outer wall of the fungal cell. It punches a physical hole in the wall, and the fungus basically leaks to death.
Okay, sounds effective.
It is. The problem is, ergosterol looks remarkably similar to cholesterol, which makes up human cell membranes. And the cells filtering your blood in your kidneys are highly exposed to the drug.
Oh, I see.
So amphotericin B gets confused, binds to the cholesterol in your kidney cells, and starts punching holes in your kidneys.
Wow, so you were basically racing to kill the fungus in their skull before you permanently destroy their body's filter system.
That's the tightrope walk, yeah.
The texts do mention alternatives like liposomal amphotericin, which wraps the drug in a fat bubble to make it less toxic to the kidneys, as well as newer drugs like fluconazole and caspofungin.
Caspofungin is interesting, actually. It attacks a completely different part of the fungal cell wall, the glucan synthesis. It's really specific, but you have to use a massive loading dose, really hitting the system hard up front.
But amidst all this terrifying lab-created chemical warfare, the amphoterrible, the steroids, the antibiotics, there's one entry in the topical therapy section that completely threw me. Manuka honey and MGO.
Right. It seems completely out of place, doesn't it? Like a 4,000-year-old remedy sitting right next to the most advanced synthetic pharmacology.
Yeah. Why is honey listed as a viable treatment for complex surgical sinus disease?
Well, because the chemistry of it is undeniably effective, especially in this age of antibiotic-resistant superbugs. Medical-grade Manuka honey contains a compound called methylglyoxal, or MGO.
And what does MGO actually do?
It destroys bacteria through multiple pathways simultaneously, which means bacteria basically can't mutate fast enough to develop resistance to it. But even beyond the MGO, honey operates on pure physics. It is highly hyperosmolar.
Meaning what?
It has very low water content, but massive amounts of sugar. If you apply a Manuka honey rinse to an infected sinus cavity, the physical laws of osmosis take over. The honey literally sucks the water straight out of the bacterial cells, dehydrating them until they implode.
That's amazing.
And treatment pulls fluid out of the swollen tissue, reducing the edema. So you have this ancient natural substance acting as a powerful physical and chemical weapon when modern antibiotics fail.
I love that. Using the physics of osmosis to just pop bacterial cells. But I mean, let's face reality. You try the honey, you hit them with the 6 weeks of macrolides, you pump them full of antifungals, and the patient comes back and the CT scan shows the polyps are still there, or the fungal ball is locked in tight behind the cheekbone.
Right, medicine has failed.
At this point, the only option left is architectural demolition.
Exactly. When the plumbing is permanently blocked, you have to tear down the walls to restore the flow.
Which brings us to the surgical protocols. But before a scalpel is ever lifted, the setup in the operating room is obsessively precise. They mandate a very specific patient positioning. Reverse Trendelenburg at 30 degrees.
Yes, this is one of those foundational rules of endoscopic surgery. You never ever operate with the patient lying completely flat.
Okay, so reverse Trendelenburg means the entire operating table is tilted, right? Feet down, head up, exactly at a 30-degree angle. Why is that angle so crucial?
It all comes down to the physics of blood flow. The nasal cavity is wildly vascular. If a patient is lying perfectly flat, their venous blood pressure in their head remains relatively high.
Makes sense.
So the moment you cut a tiny vein, blood pools directly into the sinus cavities. Your endoscope, your camera, is only a few millimeters wide. A single drop of pooled blood covers the lens, and suddenly you are completely blind inside a very dangerous cavity.
Oh, that sounds bad.
So by tilting the bed up 30 degrees, gravity pulls that venous blood back down toward the torso. It drops the hydrostatic pressure in the face just enough to give the surgeon a perfectly clear, dry surgical field.
Because if you can't see, you can't navigate. And navigating the space with a camera involves overcoming a massive sensory deficit, right?
Yeah.
You are looking at a 2D monitor, but trying to move tools in a 3D space. You lose your depth perception.
Exactly. It's incredibly disorienting at first.
The surgical notes provide these brilliant little navigational hacks, though. My absolute favorite is this line. The roof of the maxillary sinus can be used as a guide for the sphenoid sinus. It's like finding your way out of a dark forest by following the river to the big oak tree.
That's a perfect analogy. Because you have no depth perception, you can't just guess where the deep sphenoid sinus is. You might accidentally push your instrument upward into the skull base.
Which is the brain.
Right, so instead you find a rigid, predictable, bony structure, the flat roof of the maxillary sinus. You lay your instrument like a mushroom forceps flat against that roof and slide it straight back. The bone physically guides your tool directly to the safe entry point of the sphenoid sinus, bypassing the danger zones completely.
So smart. So once you've safely navigated to the diseased area, the actual demolition begins. The protocols break down a series of procedures called the draft classifications, which are specifically designed for opening up the frontal sinus behind the forehead.
Yeah, named after the German surgeon Wolfgang Graf. It's the global gold standard for this.
And reading through these, it really does sound like progressive levels of home renovation, like tearing down walls to create an open concept living room.
It dictates exactly how much bone you are allowed to remove to establish drainage.
So let's walk through the progression. Draft eye is the entry-level procedure. It's described as a simple frontal sinusotomy plus ethmoidectomy.
Right, so in your renovation analogy, draft eye is just opening a locked window. You are clearing out the ethmoid honeycomb cells directly below the frontal sinus. You aren't aggressively drilling out the heavy bone of the sinus floor. You are just sweeping away the soft tissue and thin bone, blocking the natural doorway.
But if the door's too small, you graduate to draft eye and eye. Here, the protocols say you are resecting cutting away bone between the lamina peperacea, the eye wall, and the middle turbinate, extending toward the nasal septum.
Now we are bringing out the power tools. If draft is opening the window, draft second is tearing out the window frame to make a bigger hole. You use tiny, angled, microscopic drills to physically grind away the hard bone of the frontal sinus floor. The A and B just denote how far medially towards the center of the nose you drill.
And then you reach the ultimate demolition, draft 3, also known as the MAL, the modified endoscopic Loeffler procedure. The description for this is staggering. Massive resection of the floor of the frontal sinus, the superior nasal septum, and the interfrontal sinus.
This is maximum architectural restructuring. You have two frontal sinuses, a left and a right, separated by a bony wall right in the middle of your forehead.
Okay.
In a draft third, the surgeon drills out the entire floor of both sinuses. Then they take a drill and completely obliterate the wall separating the left and right sides. Finally, they cut away the top portion of the main nasal septum. You are taking two separate diseased attic rooms, tearing down the wall between them, taking out the floor, and turning it into one massive yawning dome that drains widely into the nose. It takes hours, and the drill is spinning at thousands of RPMs near millimeters below the frontal lobes of the brain.
And making this even more complicated is the fact that human anatomy is not standard. The protocols list these specific highly variable cellular structures in the frontal recess that surgeons have to anticipate, like the Agranacci cells.
Right, which are present in about 90 to 95% of people.
Okay, what is that exactly?
The Agranacci is a mound of bone just in front of the middle turbinate. Because almost every human has it, it is the primary checkpoint. To get up into the frontal sinus, the surgeon almost always has to physically punch through the roof of this specific Agranacci cell.
But then you have the wild cards, the Kuhn cells, categorized from type I to type 2.
Yeah, Dr. Frederick Kuhn revolutionized frontal sinus surgery by mapping these wild cards. A Kuhn cell is essentially an extra ethmoid air cell that's stacked up in the wrong place during development.
How does the type change the surgery?
Well, a type I is just a single extra bubble sitting above the Agranacci. Easy to pop. Type 2 is a whole stack of bubbles. Type 3 is a massive single bubble that pushes forcefully up into the actual frontal sinus.
And type 4?
A type 4 is an isolated bubble entirely trapped inside the frontal sinus. So if a patient has a type 4 Kuhn cell blocking their sinus, a simple draft eye won't reach it. The surgeon might be forced into a massive draft third demolition just to access and remove that single rogue bubble of bone.
Wow. Now, everything we've just described is endoscopic, right? The surgeon does all of this through the nostrils using cameras, no cuts on the face. But the text also details external approaches, times when the high-tech cameras aren't enough and the surgeon actually has to take a scalpel to the outside of the face.
Yeah, endoscopic surgery is a modern marvel, but there are absolute limits to what it can achieve safely. Sometimes the bony anatomy is fused solid, or the infection is so explosive and immediate that you don't have time to carefully navigate the labyrinth.
The text mentions the Lynch-Howarth incision. It's used for accessing the anterior ethmoidal artery or draining an orbital abscess.
A Lynch-Howarth incision is an old-school open approach. The surgeon makes a curved cut through the skin right at the inner corner of the eye, like where the nose pad of your glasses rest.
Okay.
You go straight through the skin, peel back the soft tissue, break through the bone from the outside, and you are instantly inside the medial eye socket. It leaves a facial scar, but it provides immediate, wide-open access to drain pus that is threatening you.
And there's another external method that sounds downright medieval, trephination. The protocol says it involves drilling directly into the frontal sinus from the outside of the forehead for acute, complicated frontal sinusitis.
Yeah, trephination is arguably one of the oldest surgical procedures in human history. It literally means drilling a hole in the skull. If a patient arrives in the ER and their frontal sinus is locked completely shut, filling rapidly with pus under immense pressure, the bone is going to burst. And the easiest path for that pressurized pus to burst into is backward,